Bismillahirrahmanirrahim. On to the next section of our JD. So we were talking about Crohn's disease, and now let's see this picture. So in this picture, here you can see that this is what we call the cobblestone appearance. I'm sorry. Yeah. So here you can see the cobblestone appearance. This one. This is enteroenteric fistula, like connecting the two tubes, two different segments of the intestine. Here is the formation of abscess. This is the transmural inflammation as seen in the Crohn's disease, and also fibrotic strictures can form. Enteric oxaluria. So the thing that is happening is that fatty acid, first thing is decreased bile acid uptake. That decreased bile acid uptake will lead to fatty acid malabsorption. That fat and calcium will form calcium fatty acid complex, and oxalate will be spared. That oxalate will start getting reabsorbed, and urinary oxalate stones will be formed. So diseased terminal ileum, like in the Crohn's disease, can cause the formation of all of these things. Then we have pathogenesis of the gallstones and the Crohn's disease. So here you can see that the cholesterol supersaturation. Okay, starting from here. So in the Crohn's disease, there is decreased salt reabsorption, bile salt reabsorption. The bile salt will be lost in the feces, and that will decrease the reabsorption. So the bile salt pool will be decreased, and cholesterol will become supersaturated. That will lead to the formation of cholesterol stones. Then we have the USMLE point. Recurrent attacks of the right lower quadrant, pain with diarrhea and weight loss, and in a young age, that is characteristic of Crohn's disease. So Crohn's disease is a disease that is affecting the young age people who have diarrhea as well. So then the Uworld point is that the mutation in the node 2 gene have shown a particularly strong association with the Crohn's disease. Node 2 is expressed in the epithelial cells and macrophages and help regulate innate immunity. It encodes the intracellular microbial receptor that recognizes the bacterial lipopolysaccharides and subsequently activates the NFKB pathway. The NFKB is a pro-inflammatory transcription factor that increases the cytokine production. In Crohn's disease, mutation in the node 2 result in the decreased activity of the NFKB, which impairs the innate immune response of the intestinal mucosa like antimicrobial peptide synthesis and mucin secretion. The loss of this natural barrier defense allows the luminal bacteria to penetrate the submucosal tissues, causing an exaggerated response to the adaptive immune system that will lead to an increase in Th1 that result in the chronic gastrointestinal inflammation. Another Uworld point in Crohn's disease that will lead to increased activity of Th1 that causes an increase in the interferon gamma and interleukin 2 and TNF that will lead to non-caseating granuloma formation, as you can see in this picture. My circle was smaller, but the whole thing is a granuloma, a non-caseating one. Then Uworld point is the image shows an accumulation of the epithelioid macrophages. This image basically without central necrosis. This is typical appearance of a non-caseating granuloma that can be seen in Crohn's disease. Another condition which we can find non-caseating granulomas is sarcoidosis, a classic histological finding of the Crohn's disease. Then Uworld point gross picture of the Crohn's disease. There will be cobblestone appearance. Involved segment of the intestine are thick and edematous. Long serpiginous or linear ulcers with spared intervening mucosa and areas of nodular thickening lead to cobblestone appearance. Skip lesions. Diseased and healthy areas of the mucosa are sharply demarcated, forming the segments of normal mucosa interrupted by the long stretches of the disease. String sign. Inflammation of the intestinal wall almost universally leads to the narrowing of the involved intestinal segment. The strictures that commonly occur in the Crohn's disease can lead to the symptoms of chronic intestinal obstruction. Fistula formation between two adjacent lobes of intestine or between the intestine and other organs such as bladder or vagina. Perianal disease other than fistula is also common and may include skin tags and fishes, and there will be creeping fat. So this is Crohn's disease. We have seen this picture before. Let's revise it. This is cobblestone appearance, then enteroenteric fistula can form, abscesses can be present, transmural inflammation and fibrotic strictures are common. So here you can see that colonic cross section. This is the mesentery. So mesentery starts in encircling the diseased bowel. So basically it is hugging the diseased bowel, and that is creeping flat. And string sign is like this is the lumen that has become so thin that it is looking like a string. I think now it is more visible. So this is the mucosa. This is not the mucosa. I'm sorry. This is the intestinal loop that has becomes so inflamed that the lumen is so narrow that when we give the barium swallow, so the barium forms a very thin line that is apparent on X-ray, and that is called as the string sign. The Uworld point Crohn disease causes oxalate kidney stones. How? Calcium normally binds to oxalate in the intestine and excreted. Calcium normally binds to oxalate and both of them are excreted. In Crohn disease, there is malabsorption that causes an increase in fat in stool which binds the calcium, preventing it from binding the oxalate. That causes oxalate absorption and causes the formation of oxalate stones. The usual point is Crohn's plus gallbladder stone causes the cholesterol gallbladder stones. Mechanism is decreased bile absorption in the terminal ileum will lead to cholesterol precipitate and form the gallstones. Another point is extra-intestinal complication of the inflammatory bowel disease. In the skin, it causes pyoderma gangrenosum, more with ulcerative colitis. Pardon me for that, and erythema nodosum. And in the joints, arthritis and ankylosing spondylitis is common. In the eyes, we can find iritis, uveitis, and episcleritis. In the liver, primary sclerosing cholangitis more common with ulcerative colitis, and there is also a risk of cholangiocarcinoma. Then another useful point is that ulcerative colitis has following unique characteristics. So the unique characteristics of ulcerative colitis are the rectum is always involved. Inflammation is limited to the mucosa and submucosa only. The mucosal damage is continuous. There are no areas of normal mucosa between the affected segments. Bloody diarrhea with or without abdominal pain is the hallmark of ulcerative colitis. In Crohn disease, there may also be bloody diarrhea, but abdominal pain is virtually always present with the Crohn disease. Okay, so the abdominal pain may be absent in ulcerative colitis, but bloody diarrhea will always be present, and the reverse is true for the Crohn disease. Then toxic myocolon is a complication of both, but more common with ulcerative colitis. This is toxic myocolon, as you can see this dilated intestinal loop like all of this. Mechanism is neuromuscular degeneration of the intestinal wall that will cause rapid dilation. The clinical picture is abdominal pain and distension with fever, diarrhea, signs of shock that is increased heart rate and decreased blood pressure. Next step is plain abdominal X-ray. Colon diameter more than 5.5 centimeter, barium enema and colonoscopy are contraindicated. Free air may also be visualized in setting of intestinal rupture, which presents with generalized peritonitis like abdominal rebound tenderness and guarding. Toxic megacolon can also be associated with Clostridium difficile infection and other forms of infectious colitis. Then we have irritable bowel syndrome. Recurrent abdominal pain associated with more than two of the following. That is, irritable bowel syndrome is related to the defecation and there is change in stool frequency. Change in form, that is consistency of the stool. No structural abnormalities, most common in the middle-aged women. Chronic symptoms may be diarrhea predominant, constipation predominant, or mixed. Pathophysiology is multifaceted, and the first line treatment is lifestyle modification and dietary changes. The USMLE point is treatment of diarrhea with inflammatory bowel syndrome is loperamide and diphenoxylate. So you must be able to differentiate between the syndrome and disease. Syndrome is basically a psychiatric condition, and the disease is the one with the Crohn disease and ulcerative colitis. Now let's talk about appendicitis. As the name indicates, it is the inflammation of the appendix. Acute inflammation of appendix, as depicted by the yellow arrows, can be due to obstruction of the fecal health. Like this is appendix, this is a vestigial organ. So if feces obstruct the lumen of appendix, there will be inflammation, and then inflammation will lead to appendicitis. In adults or lymphoid hyperplasia in children, lymphoid hyperplasia is a cause of obstruction of lumen in the children. Initial diffuse periumbilical pain migrates to McBurney point, 1/3 distance from the right anterior superior iliac spine to the umbilicus. Nausea, fever may perforate, so there will be nausea, there will be fever, and it may also perforate, causing peritonitis. May elicit sauce, obturative, Rovsing sign, guarding, and rebound tenderness on exam. The differentials include diverticulitis in elderly, ectopic pregnancy, use of beta HCG to rule out use the beta HCG to rule out pseudoappendicitis. Like if it is ectopic pregnancy in the right fallopian tube, so that can also look like appendicitis. So basically do the beta HCG test in the women of reproductive age to rule out ectopic pregnancy. Then the uval point is obstruction of the lumen of the appendix is the first event in the pathologies of pathogenesis of acute appendicitis. Picolets, hyperplastic lymphoid follicles, foreign bodies or tumor may cause the obstruction. The most common obstructing agents are picolets. Then diverticula of the GI tract. Firstly, what is diverticulum? Diverticulum is a blind pouch protruding from the alimentary tract that communicates with the lumen of the gut. Most diverticulum, esophagus, stomach, duodenum, colon are acquired and they are false diverticula. False means that all layers of the affected part of the GIT are not involved. Like all the layers are not involved. Or like mucosa, submucosa, muscularis propria, serosa. These are the layers of any affected part of the gut. All layers are not herniating. Only the mucosa and submucosa are herniate outwards, and that is false diverticulum. In a true diverticulum, all the gut wall layers outpouch, for example, Meckel's diverticulum. In false diverticulum or pseudo diverticulum, only mucosa and submucosa outpouch. It occurs especially where the vasa recta perforate the muscularis externa in the colon basically. Diverticulosis. Many false diverticle of the colon, commonly sigmoid, common in about 50% of the people more than 60 years of age. It is caused by increased intraluminal pressure and focal weakness in the colonic wall and associated with obesity and diets low in fiber, high in total fat and red meat. Often asymptomatic or associated with vague discomfort. Complications include diverticular bleeding, painless hematochezia, and diverticulitis. The diverticulitis is the now diverticulosis is common, like the person is asymptomatic. Maybe there is painless bleeding, or but otherwise the person will be asymptomatic. But if there is inflammation of that diverticulum, that is called diverticulitis. Okay. So this is diverticulosis, and here we have diverticulitis. Okay. Inflammation of the diverticula with wall thickening, classically causing the left lower quadrant pain, fever, leukocytosis, and treat with antibiotics. Complications include abscess, fistula, that is colovesical fistula that will lead to pneumaturia, obstruction, inflammatory stenosis, perforation, and peritonitis. The Uworld point is that diverticulosis, most patients are asymptomatic, but some patients may present with hematochezia due to disruption of arterioles adjacent to the diverticulum. Then comes the Zenker's diverticulum, the pharyngoesophageal false diverticulum. Esophageal dysmotility causes herniation of the mucosal tissue at the Killian triangle between the thyropharyngeal and the cricopharyngeal parts of the inferior pharyngeal constrictor, presenting symptoms like dysphagia, obstruction, and gurgling, aspiration, foul breath, and neck mass, most common in elderly males. So the elderly Mike has bad breath. Like Zenker's diverticulum is common in the elderly, males, inferior pharyngeal constrictor is involved in the Killian's triangle specifically, and esophageal dysmotility is a risk factor, and halitosis will be the outcome of that. Like it will be presenting complaint. So this is like Zenker's diverticulum. It's happening in the inferior posterior constrictor muscle, inferior pharyngeal constrictor muscle. So this is a false diverticulum. Esophageal obstruction and dysphagia will happen because of the food being accumulating in the Zenker's diverticulum. Impaired cricopharyngeal relaxation causes that, and pulmonary aspiration can also occur. So this is a Zenker's diverticulum. This is also a Zenker's diverticulum. Tricuspid aspiration and esophagus. Okay. Pathophysiology of Zenker's diverticulum: diminished relaxation of cricopharyngeal motor dysfunction. So cricopharyngeal muscle during swallowing results in increased intraluminal pressure in the oropharynx. This may eventually cause the mucosa to herniate through the zone of muscle weakness in the posterior hypopharynx, forming a Zenker diverticulum, which is a false diverticulum. Deglutition swallowing is a complex process that involves three phases. The voluntary oral phase, the food bolus is collected in the back of mouth and lifted upwards to the posterior wall of the pharynx. This initiates the pharyngeal phase, which consists of involuntary pharyngeal muscle contraction that propels the food bolus to the esophagus. During the esophageal phase, food stretches the wall of esophagus, stimulating the peristalsis just above the site of distension and moving the food downward. Relaxation of the lower esophageal sphincter follows, allowing the food bolus to enter the stomach. Now let's talk about Meckel's diverticulum. So this is a true diverticulum, and persistence of the vidline or the omphallomesenteric duct may contain ectopic. Omphallomesenteric duct is basically a connection between the yolk sac and the gut and the embryonic gut, and that is mostly obliterated. But if it is persistent, that can lead to the formation of Meckel's diverticulum. So it may contain the ectopic acid secreting gastric mucosa and or pancreatic tissue. Most common congenital abnormality of the GIT. It can cause hematochezia, melena, that is less common, left right lower quadrant pain, intussusception, volvulus or obstruction near the terminal ileum. Contrast with omphallomesenteric cyst, that is cystic dilation of the vidline duct. Diagnosis is per technitate study for uptake of heterotopic gastric mucosa. So here you can see umbilicus Meckel's diverticulum is present over here. Meckel's diverticulum has rules of two. 2 times likely in males, 2 inches long, 2 feet from the 2% population is affected. Commonly present with first 2 years of life and may have two types of epithelia, that is gastric or pancreatic. These are ectopic, epithelium that can be present in that, and if they are present there, so they can lead to ulceration or maybe perforation, and that can be very devastating. So, Hirschsprung disease, a disease that is characteristically found in the people with the Down syndrome. So, it is congenital megacolon characterized by the lack of ganglion cell or enteric nervous plexuses, Oribag or Meissner in the distal segment of the colon due to the failure of neural crest cell migration. We have talked about that in detail when we were doing the embryology. It is associated with a mutation in the RET gene. It presents with bilious emesis, abdominal distension, and failure to pass the meconium within 48 hours that will result in chronic constipation. Normal portion of the colon proximally to the aganglionic segment is dilated, resulting in the transition zone. Risk increases with Down syndrome. Explosive expulsion of feces, that is cord sign, lead to empty rectum on digital exam. The diagnosis, it is diagnosed by absence of ganglionic cells on the rectal suction biopsy. So we do the rectal suction biopsy. Basically, we don't take the mucosa only. We do the suction biopsy in which all the layers of the rectum are taken, and then we look for the presence or absence of mesenteric or Oribag plexus. And in the diseases like Hirschsprung disease, they're absent. Treatment is dissection. So RET mutation in the rectum. So the clinical manifestations, the clinical features include bilious, vomiting, abdominal distension, failure to pass the meconium, failure of the internal anal sphincter relaxation, that is tight anal sphincter, and large colon, that will be megacolon, because this is not relaxing. This is food feces cannot pass into this segment, so resultantly they start accumulating proximal to that, and that will result in megacolon. Aganglionic segment lacks nerve cells and cause distal intestinal obstruction. Then another Uworld point is that rectum is always affected in the Hirschsprung disease as the neural crest cells migrate caudally. So if this is a hypothetical picture of a child, neural crest cells start descending downwards. So if there is problem in in this descending pathway, so the most distal portion is the rectum to be innervated. So the rectum will always be involved in Hirschsprung disease. NBME point is that the aganglionic segment is narrow because it cannot relax, and there is compensatory dilation of the proximal segment. The diagnosis is failure to pass meconium in the first 48 hours of birth with bilious emesis. Perform the rectal biopsy. Sampling in Hirschsprung disease, submucosa of the narrow part of the rectum, and that can be taken by suction biopsy. Hirschsprung disease, tight anal sphincter, empty rectum, and colon distension will be present. How do we differentiate Hirschsprung disease from meconium medius? So, Hirschsprung disease, the associated disorder is Down syndrome. Typical level of obstruction is recto-sigmoid. Meconium consistency will be normal and squat sign will be positive. In meconium ileus, that is seen in the cystic fibrosis. So associated disorder, cystic fibrosis, the typical level of obstruction is ileum. Meconium consistency, it will be inspissated, that is thickened, and squat sign will be negative. Now let's talk about malrotation. You know that rotation of the intestine is a normal mechanism that happens during the embryonic life. So like in this, when the intestines are being produced, and they are enlarging in size, so they herniate outside from the umbilicus, and they undergo a total 270-degree rotation. So um, uh, um, let's restart from malrotation. So basically, I was saying that the intestine herniate during the intraembryonic life. They undergo 270-degree malrotation, and then they come back. If there is some problem with that malrotation process, so that can result in many different kind of problems. So anomaly of midgut during midgut rotation during the fetal development, improper position of the bowel, small bowel clumped on the right side. As you can see, this small bowel is on the right side and the large bowel on the left side. And there is formation of lead bands can lead to volvulus duodenal obstruction. So these lead bands can lead to duodenal obstruction. So here you can see in this picture, like these are the small intestines, and this is what colon may be, but the small bowel is clumped on the right side and large bowel is directed to the left side. The volvulus is twisting of the portion of bowel around its mesentery. Malrotation, it is a kind of malrotation in which the bowel is, but it is not congenital malrotation. It can happen later on in life, like it is happening in the areas of the bowel which are free to rotate, and when they rotate around their own mesentery, they obstruct the blood supply. They can lead to obstruction and infarction. It can occur throughout the GAT. Midgut volvulus more common in infants and children. Sigmoid volvulus coffee bean sign on X-ray is more common in elderly population. As you can see, this is coffee bean sign or inverted U sign. It is sometimes referred to as omega sign as well. So these are common. Then the next thing is interception. So interception means telescoping of the proximal bowel segment into the distal segment, commonly at the ileocecal junction. Compromised blood supply lead to intermittent abdominal pain with current jelly stool. Patients may draw the legs to the chest to ease the pain. Uh, if you remember, the same kind of maneuver was also seen in tetralogy of palate and CVS. Like the knee to chest maneuver was performed to alleviate the dead spells, and the similar maneuver is also helping relieve the pain of interception. Exam may reveal sausage-shaped mass. Ultrasound shows target sign, often due to often due to a lead point, but can be idiopathic as well. Most common pathologic lead points are Macus diverticulum, children, or intraluminal mass or tumor in adults. Majority of the cases occur in children and unusual in adults. It may be associated with the rotavirus vaccine, Knox purpura, and recent viral infection like adenovirus spire patch hypertrophy creates lead point. The Uworld point is that most typical location for interception is at the ileocecal junction. The size differences in the adjacent segments of the intestine allow the small bowel to invaginate into the cecum. Interception is most common in children younger than 2 years old. In this age group, it can occur without any structural cause, sometimes associated with a viral infection. In patients older than 2 years of age, a lead point such as Macus diverticulum, foreign body, or intestinal tumor should be sought. Then barium enema is diagnostic and may be therapeutic. If the intersection does not resolve with the barium enema, surgical intervention is mandated. Okay, so actually we give barium enema. So barium enema on one hand it is diagnostic, but along with that it can also be therapeutic because of giving barium enema that can relieve these intersection symptoms and ultimately result in the betterment of the symptoms. Then mesenteric ischemia. So acute mesenteric ischemia, chronic and colonic ischemia. So acute mesenteric ischemia, as the name indicates, is the ischemia of the small intestine under acute settings. So it is critical blockage of intestinal blood flow, often embolic closure of the superior mesenteric artery that will lead to small bowel necrosis, abdominal pain out of proportion to the physical findings, and may see red current jelly stools. The chronic mesenteric ischemia or intestinal angina, it is caused due to atherosclerosis of celiac artery, superior mesenteric artery or inferior mesenteric artery that leads to intestinal hypoperfusion, postprandial epigastric pain and food aversion and weight loss. The colonic ischemia, reduction in the intestinal blood flow causes ischemia, crampy abdominal pain followed by hematochezia, commonly occurs at watershed areas like splenic fracture of distal colon, typically affects the elderly, thumbprint sign on imaging due to the mucosal edema and hemorrhage. Ischemic colitis, thumbprint appearance on X-ray. So for the ischemic colitis, what do we see in X-ray? There will be a thumbprint appearance. Then another Uworld point is chronic mesenteric ischemia lead to atherosclerotic narrowing of the celiac trunk, superior mesenteric artery and inferior mesenteric artery. The pathogenesis, it is similar to angina pectoris. When atherosclerosis involves the mesenteric arterioles, the bowel can suffer from diminished blood supply. Intestinal hypoperfusion, which can be very painful, is especially pronounced within an hour after the meals when more blood is needed for the digestion absorption of the nutrients, that is intestinal angina. The clinical presentation is epigastric or periumbilical pain occurs 30 to 60 minutes postprandial. Patients report severe pain, but physical examination is usually benign. Weight loss, the patient fears to eat. Light microscopy, mucosal atrophy and loss of villi. The diagnosis is angiography, expensive and invasive, and mesenteric duplex ultrasound. You will point about a 72 years old Caucasian male develops hypotension during the surgical repair of an abdominal aortic aneurysm. Post-operatively, he develops abdominal pain or bloody diarrhea. Which of the following portion of the large bowel is most likely to be affected by this patient's condition? The answer is splenic fracture because it is a watershed area. The diagnosis is ischemic colitis secondary to the systemic hypotension. The splenic fracture and distal sigmoid colon are the most susceptible. The splenic fracture is a border area between the distribution of superior mesenteric artery and inferior mesenteric arteries. The distal sigmoid colon lies between the area supplied by the inferior mesenteric artery and hypogastric arteries, and ischemia affects the areas first and is called as watershed infarction. Clinically, patients present with abdominal pain and bloody diarrhea. Angiodysplasia, tortuous dilation of vessels, leads to hematochezia, most often found in the red-sided colon, more common in older patients. Confirmed by angiography associated with the aortic stenosis and von Willebrand disease. Then comes adhesions. Fibrous bands of scar tissue commonly forms after surgery. Most common cause of small bowel obstruction, demonstrated by the multiple dilated small bowel loops on X-ray, Ileus, intestinal hypomotility without obstruction, constipation and decreased platus, distended tympanic abdomen with decreased bowel sounds. Associated with the abdominal surgeries, opiates, hypokalemia, sepsis. Treatment is bowel rest, electrolyte correction, cholinergic drugs, and cholinergic drugs stimulate the intestinal motility. Hematochezia in old age mostly due to high stress in the left side of the colon. So if there is high stress on the left side of the colon, that will result in diverticulosis and that will cause hematochezia. And if there is high stress on the right side of the colon, that is going to cause angiodysplasia. Okay. Hereditary hemorrhagic telangiectasia or Osler-Weber-Rando syndrome. Osler, not Weber, Osler-Rando syndrome. I think it is Weber as well. Okay. So autosomal dominant disorder resulting in thin walled blood vessels, sites especially the nasopharynx and GIT, and rupture will present with bleeding. Another Uworld point is HIV positive with bloody diarrhea and multiple hemorrhagic polypoids and spindle shaped surrounding blood vessel proliferation. It is positive sarcoma in the GIT. Then comes a person with HIV with a CT scan of abdomen shows ascites and large mass surrounding the small intestine on biopsy. So uniform round medium sized tumor cell with basophilic cytoplasm with proliferation it is Ki67 fraction more than 99%. The answer is Burkitt's lymphoma. High mitotic index is typical for the Burkitt's lymphoma. Okay, so colonic manifestations of various diseases. In adenocarcinoma, the colonoscopic finding is that it is usually a protuberant mass, and biopsy is dysplastic mucosal cells with variable degree of gland formation, cytomegalovirus, multiple ulcers and mucosal erosions, and cytomegalic cells with inclusion bodies, cryptosporidium, non-ulcerative inflammation, and basophilic clusters seen on the surface of the intestinal mucosal cells, and amoeba histolytica, numerous discrete flask-shaped ulcerative lesions, trophozoites containing red blood cells, then Kaposi sarcoma, reddish violet, flat maculopapillar regions of the hemorrhagic nodules. So on biopsy, spindle-shaped tumor cells with small vessel proliferation, and in ulcerative colitis, contiguous area of erythematous friable granular mucosa with possible pseudopolyps, and inflammatory infiltrates involving the mucosa and submucosa with the crypt abscess will be seen on biopsy. What is necrotizing enterocolitis? It is a pediatric problem. It is seen in premature formula-fed infants with immature immune system. Necrosis of intestinal mucosa, primarily colonic with possible perforation, which can lead to nematosis intestinalis, free air in the abdomen, and portal venous gas. Then necrotizing enterocolitis explanation. Necrotizing neck is one of the most frequent gastrointestinal emergencies affecting the newborns. It occurs predominantly in the preterm infants, secondary to the gastrointestinal and immunologic immaturity. Upon initiation of the enteral feeding, bacteria are introduced into the bowel where they proliferate excessively due to the compromised immune clearance. Impaired mucosal barrier functions allow the bacteria to invade the bowel wall, causing inflammation and ischemic necrosis of the terminal ileum and colon. As the disease progresses, the bowel becomes congested and gangrenous with the formation of intramural gas collections, causing pneumatosis intestinalis, that is, air in the bowel wall, which can be seen on abdominal X-ray as thin, curvilinear areas of lucency that parallel the lumen. In an infant with abdominal distension and bloody stools, this finding is diagnostic for the necrotizing enterocolitis. Okay, so pneumatosis intestinalis is a very important hallmark. Like the air fluid levels will be seen of the for the necrotizing enterocolitis. Up to 30% of the affected neonates die, especially when disease is complicated by intestinal perforation. Survivors are at risk of strictures and bowel obstruction secondary to fibrosis that occurs as the inflammation subsides. What are the features of Clostridium difficile colitis? The risk factors are recent antibiotics, hospitalization, advanced age and PPIs. Pathogenesis is intestinal overgrowth of C. diff. Clostridium difficile leads to toxin production. Enterotoxin A causes water diarrhea, and cytotoxin B causes colonic epithelial cell necrosis and fibrin deposition. The clinical presentation is fever, abdominal pain, watery diarrhea, and leukocytosis. It ranges from mild watery diarrhea to fulminant colitis, that is toxic megacolon. Characteristic white yellow pseudomembranes on sigmoidoscopy will be seen. The diagnosis is done with a PCR detection of the toxin gene in the stool, and treatment is metronidazole or oral vancomycin. Colonic polyps. Growth of the tissue within the colon may be neoplastic or non-neoplastic, grossly characterized as fat, sessile, or pedunculated on like pedunculated means like to be on a stalk on the basis of protrusion of the colonic lumen, generally classified by the histologic type. So for the histological type, they are classified as the following. The ones which are generally non-neoplastic are the following, and then the ones with the malignant potential are these two. So the one which are non-neoplastic are hematomatous, mucosal, inflammatory, submucosal, and hyperplastic. Hematomatous polyps are solitary lesions, do not have significant risk of transformation. Growths of normal colonic tissue with distorted architecture, and they are associated with the Peutz-Jeghers syndrome and juvenile polyposis. Mucosal polyps are small, usually less than 5 mm, look similar to the normal mucosa, and they are clinically insignificant. Inflammatory pseudopolyps are due to mucosal erosion in the inflammatory bowel disease. Submucosal polyps may include lipoma, leiomyoma, fibroma, and other lesions. And the hyperplastic polyps, most common, generally smaller and predominantly located in the rectosigmoid region, occasionally involves into serrated polyps and more advanced lesions. Adenomatous polyps, they are neoplastic via chromosomal instability pathway with mutation in the APC and KRAS. Tubular histology has less malignant potential than the villus. Villus histology is villainous. The tubular villus has intermediate malignant potential, usually asymptomatic, may present with occult bleeding. Serrated polyps, they are pre-malignant, characterized by the CPG island methylator phenotype, CIMP, that is CPG island methylator phenotype. Cytosine base is followed by guanine and linked by a phosphodiester bond. Defect may silence the MMR gene, DNA mismatched pair. Okay, expression. Mutation lead to microsatellite instability and mutation in the BRAF, sawtooth pattern of crypts on the biopsy. Up to 20% of the cases are sporadic. Up to 20% cases of sporadic colorectal cancer have serrated polyps with a deleted MMR gene and SIM phenotype. Okay, so this is polyp cancer and this is also a polyp. These are villus histology, this is tubular histology. Now, adenomatous polyps. Adenomatous polyp is the second most common type of colonic polyp, benign but pre-malignant, may progress to adenocarcinoma via adenoma-carcinoma sequence. Type of adenomatous polyps are tubular adenomas are composed of dysplastic colonic mucosal cells that form the tubular-shaped glands, smaller and pedunculated. The villus adenomas are dysplastic epithelial cells form villi-like projections that extend from the polyp surface down to the stroma, larger and more commonly sessile, velvety or cauliflower-like projections, more severely dysplastic, bleeding, secretory diarrhea, partial intestinal obstruction. The tubular villus adenomas show a mixture of two patterns. Got it. Symptoms of colonic adenomatous polyps. All the most colon adenomas are asymptomatic. Larger ones can cause a number of symptoms, including the lower intestinal bleeding, which will be brighted, hematochezia, partial intestinal obstruction, villus adenomas, and villus adenomas again. So basically they cause diarrhea and adenocarcinoma. So lower intestinal bleeding cause Goyak positive stool, fecal occult blood testing, and microsatellite and microcytic hypochromic anemia. The bleeding is usually unknown to the patient, but overt bleeding may also occur. The partial intestinal obstruction can manifest with a bowel habit, changes, crampy abdominal pain, constipation, and abdominal distension. The villus adenomas may secrete large amount of mucus leading to secretory diarrhea, and the villus adenomas have high risk of progression to adenocarcinomas. Then comes the Peutz-Jeghers syndrome. It is associated with multiple hematomatous polyps and black stool, black spot in the skin and mucosa of young people. Okay, the malignant potential of adenomatous polyp is determined by the following: size, histologic appearance, and degree of dysplasia. The size of polyp, if it is less than 1 centimeter, it is unlikely to undergo malignant transformation. More than 4 centimeter, 40% risk of malignancy. Histologic appearance, villus adenomas are more prone to be malignant than the tubular adenomas, and then the degree of dysplasia is the very important hallmark for determining the chances of malignancy. Then comes the types of non-neoplastic polyps. So these are hyperplastic, inflammatory, submucosal, and mucosal. We have talked about them, but let's revise them. So hyperplastic polyps are composed of well-differentiated mucosal cells that form the glands and crypts. Inflammatory polyps seen in ulcerative colitis and Crohn's disease, they are composed of regenerating intestinal mucosa. Submucosal structures like lipomas, lymphoid aggregates that bulge up into the mucosa, and mucosal polyps fold in the colonic mucosa that resemble the polyps but are made of normal mucosa. Okay, so the non-neoplastic polyps are serrated hematomatous and adenomatous tubular villus or tubular villus. Well, the non-neoplastic polyps are hyperplastic, submucosal, inflammatory, and mucosal. Now let's talk about KRAS mutation causing the anti-EGFR resistance. So the EGFR inhibitor, these are the drugs that we administer. So they inactivate the EGFR. In wild type KRAS, limited cell growth and proliferation occurs in response to the EGFR inhibitors. But for the mutated KRAS, it does not require the EGFR stimulation. It is independently causing the cell proliferation. So uncontrolled cell proliferation resistant to anti-EGFR therapy. Then we have certain syndromes which are called as polyposis syndromes. So these include familial adenomyosarcomas polyposis. It is autosomal dominant mutation in the APC tumor suppressor gene on the chromosome 5q21. Two-hit hypothesis is present. Like two-hit hypothesis means that one gene was defected when the child was born and second hit occurs during the lifetime, and that results in both the genes to be abnormal, and ultimately the syndrome occurs. Thousands of polyps arise starting after puberty. Pancolonic always involves rectum. Prophylactic colectomy or else it will progress to the colorectal cancer in 100% of the situations. Then is the Gardner syndrome. So Gardner syndrome is familial adenomyosarcomas polyposis with osseous and soft tissue tumors, congenital hypertrophy of retinal pigment epithelium, and impacted supernumerary teeth. Turcot syndrome means familial adenomyosarcomas polyposis or Lynch syndrome with malignant CNS tumors like medulloblastoma and glioma. So Turcot is for the turban. Turban is, a head dress. So Turcot syndrome can cause CNS tumors. Then Peutz-Jeghers syndrome, autosomal dominant syndrome featuring the membranous hematomas throughout the GIT, along with hyperpigmented mouth, lips, hands, and genitalia. It is associated with the increased risk of breast and GI cancers like colorectal, stomach, small bowel, and pancreatic. Juvenile polyposis syndrome, autosomal dominant syndrome in the children, typically less than 5 years old, featuring numerous hematomatous polyps in the colon, stomach, small bowel, and they are associated with the increased risk of colorectal cancer. Lynch syndrome, previously known as hereditary non-polyposis colorectal cancer, autosomal dominant mutation of the DNA mismatch repair gene with subsequent microsatellite instability, about 80% progress to the colorectal cancer. Proximal colon is always involved. It is associated with the endometrial, ovarian, and skin cancers. The Uworld point about the colon cancer occurs at a young age, that is less than 50 years old, with family history reveals high incidence of colon and other cancers in the first degree relatives that lead to hereditary non-polyposis colorectal cancer or Lynch syndrome. There are two types of Lynch syndrome, Lynch 1 and Lynch 2. Lynch 1 is characterized by the family predisposition to the colon adenocarcinoma. Lynch 2 causes predisposition to the colon cancer with the features common to Lynch 1 and increased incidence of extraintestinal cancers, endometrial and ovarian carcinoma, cancers of stomach, pancreas, and urothelial tract, among others, may also occur. Colon adenocarcinoma and the HNPCC have some specific features shown in the table. So, like it is hereditary non-polyposis colorectal cancer, the age of occurrence. HNPCC associated colon adenocarcinoma occurs younger than 50 years of age, location predominantly right side. Multiple cancers are common. Synchronous occurs simultaneously with the primary tumor, and metachronous occurs after the resection of the primary tumor. The source is macroscopically normal areas of the dysplastic mucosa. Genetic basis is mutation in the DNA mismatch repair genes MLH1, MSH2, MSH6, and PMH2. Sporadic colon adenocarcinoma occurs in the people older than 50 years of age. Location is predominantly left-sided. Multiple cancers are uncommon. Source is adenomyosarcomas polyps, and genetic basis is adenocarcinoma sequence. Mutation in APC, then KRAS, P53, or DCC can lead to the formation of this thing. Microsatellite instability is depicted in this picture. So this is DNA polymerase, and microsatellite 6 repeats. Extra repeat caused by the replication slippage in the normal DNA mismatch repair. This is not incorporated into the DNA, but in the deficient DNA mismatch repair, this is incorporated, and non-functional protein with 7 repeats will be formed. So colorectal cancer. The epidemiology: most patients are more than 50 years of age. About 25% have a family history as well. The risk factors include adenomyosarcomas and serrated polyps, familial cancer syndrome, inflammatory bowel disease, tobacco use, diet of processed meat with low fiber. The presentation: retrosigmoid, then ascending and descending colon. Ascending colon, there is exophytic mass, iron deficiency, anemia, and weight loss. In the descending colon, there will be an infiltrating mass, partial obstruction, colicky pain, and hematochezia. Rarely present with Streptococcus bovis or Carolyticus, that is bacteremia. Right-sided bleeds, left-sided obstructs. that causes the lumen to become narrower. Diagnosis: iron deficiency anemia in males, especially more than 50 years old, and postmenopausal females raise the suspicion. Screen low risk patients starting at age 50 with colonoscopy. Alternatives include flexible sigmoidoscopy, fecal occult blood testing, fecal immunochemical testing FIT, and CT colonography. Patient with a first-line degree relative who has colon cancer should be screened via colonoscopy at age 40 or starting 10 years prior to their relative's presentation. Patient with inflammatory bowel disease have a distinct screening protocol. Apple core lesions on the barium enema or X-ray like these can be seen, and the carcinoma embryonic antigen tumor marker is good for monitoring recurrence and should not be used for screening. Like the CEA is not very sensitive, so we are not using it for screening purposes. But when we are giving the therapy to maybe chemotherapy or maybe after completion of the treatment to check for the recurrence, we can use CEA. So this is the polyp, and here is the apple core lesion seen on the barium enema X-ray. So Uworld point is right-sided colon cancer usually grows as exophytic masses. Patients generally do not develop intestinal obstruction because the ascending colon has a larger caliber lumen than the descending colon, and stool in the proximal colon is more liquid. Right-sided colon cancer typically present with the features of iron deficiency, anemia, for example, fatigue, pallor due to the occult blood loss. Non-specific symptoms such as anorexia, malaise, and unintentional weight loss may also occur. Left-sided colon cancer tend to infiltrate the intestinal wall and encircle the lumen, causing a change in the bowel habit like constipation, and symptoms of intestinal obstruction like abdominal pain, distension, nausea, and vomiting. What is the molecular pathogenesis of the colorectal cancer? So this is the normal colon. If there is loss of APC gene, so there will be decreased intracellular adhesion and increased proliferation that will increase the risk of colon cancer. Now, in this risky epithelium, if there is KRAS mutation, so there will be unregulated intracellular signaling that will cause the adenoma formation. And in this adenoma, if there is deletion or mutation in the P53 or DCC gene, that will cause tumorigenesis and carcinoma formation. The chromosomal instability pathway, mutation in the APC gene, familial adenomatous polyposis, and more sporadic colorectal cancer via adenoma carcinoma sequence. So it is Fring order of events in AK53. Okay. So microsatellite instability pathway mutation or methylation of mismatched repair genes, for example, MLH1, cause the Lynch syndrome and some sporadic colorectal cancer via serrated polyp pathway. Overexpression of COX2 has been linked to the colorectal cancer. NSAIDs may be chemo preventive as well. So again, this is the normal colon. In case of APC inactivation, there will be hyperproliferative epithelium. Methylation abnormalities will be present and COX2 overexpression will be there. If there is KRAS mutation in this hyperproliferating epithelium, so that will result in adenoma formation. If there is DCC inactivation or P53 inactivation, that will result in the carcinoma formation, and further accumulation of genetic abnormalities can also occur because of the tumorigenesis. When the tumor has been formed, there is so much cell proliferation that further mutations are also prone to happen in the tumor. The Uworld point, the transformation of the normal mucosal cell into malignant one is caused by a series of gene mutation called the adenoma to carcinoma sequence. This sequence includes the following steps: 1, 2, 3. Progression from normal mucosa to small polyp. The initial appearance of small adenomatous polyp is attributed to the mutation of APC tumor suppressor gene. Increase in size of polyp. Mutation of the KRAS proton gene is thought to facilitate the step by step to this step by leading to the uncontrolled cell proliferation. And malignant transformation of adenoma into carcinoma requires mutation of two genes, P53 and DCC. The colorectal cancer from ulcerative colitis differs from the sporadic colorectal cancer in that it affects the younger patients, progresses from flat and non-polypoidal dysplasia. Sporadic colorectal cancer often arises from polypoid lesions. This is in contrast to colitis-associated carcinoma, which often arises from flat dysplastic lesions, thus making an early diagnosis more difficult. Higher grade than sporadic carcinoma histologically appear mucinous and or have signature morphology. They develop early P53 mutations and late APC gene mutation opposite that of the sporadic disease. Be distributed within the proximal colon, especially with the Crohn's disease or concurrent primary sclerosing cholangitis, and they are multifocal in nature as well. So the colorectal cancer in the case of ulcerative colitis is multifocal in nature. The risk of developing colorectal cancer from the inflammatory bowel disease is dependent mainly on the duration. Usually develops after 10 years of the colitis. Pancolitis, like the inflammation of the whole colon, is associated with the highest risk of colorectal cancer. Then the overall point is that cancer colon with more than 50 years of age and a family history and other malignancies as endometrial carcinoma, the diagnosis is hereditary non-polyposis colorectal cancer or Lynch syndrome that is caused by the DNA mismatch repair gene mutation. The patient inherits one allele gene and mutation occurs in the other one in the adult life. Carcinoembryonic antigen level is increased in the colon cancer as well as in other malignancies and certain benign diseases. CEA cannot be used to diagnose the colon cancer, but it is helpful for detecting the disease recurrence. CEA is a glycoprotein involved in cell adhesion. Then carcinoid syndrome. It is important. Carcinoid syndrome is basically a tumor of the small bowel. Although I previously said that small bowel tumors are very rare, but carcinoid syndrome is one of the tumors that can occur. So it is a rare syndrome caused by carcinoid tumors, neuroendocrine cells. Malignant transformation of the neuroendocrine cells, most commonly located in the gastrointestinal tract, for example, small intestine, rectum, and appendix, followed by the bronchopulmonary system. Most common malignancy in the small intestine. Histology shows prominent rosette. Like this is rosette means floral appearance, composed of islands or sheets of uniform cells with eosinophilic cytoplasm and oval to round stippled nuclei. Cells will fried egg-like appearance. Cells will give us a fried egg-like appearance. Prominent in metastatic cells, metastatic small bowel tumors. So carcinoid syndrome will not occur in the localized small bowel tumors because if it is suppose the small bowel and this is liver, so the tumor will be producing serotonin and other metabolites that will be taken to the liver by the portal system and liver will detoxify them. But if they have metastasized all the way to the liver itself, the tumor has metastasized to the liver. Now the harmful substances, the serotonin and other contents of the tumor, they will be secreted directly into the blood without liver being able to detoxify them, and ultimately serotonin syndrome will occur. Now, the thing that we are going to talk about now is prominent in metastatic small bowel tumor which secretes high level of serotonin, not seen if the tumor is limited to the GAT. Serotonin undergoes the first pass metabolism in the liver. Then appendiceal carcinoids typically have a benign course but may cause appendicitis or rarely carcinoid syndrome, for example, with the liver metastasis. The clinical presentation in the skin, they cause flushing, telangiectasias and cyanosis. In the GAT, they will cause watery diarrhea and cramping. In the pulmonary system, bronchospasm, dyspnea, and wheezing is common. For the cardiac manifestation, the valvular fibrosis, plaques, and they're more common on the right side than the left side. Why so? Because I said that these serotonin and stuff like that, they're being released in the veins, right? So when the veins are carrying the blood, veins enter into the right heart first, and to the right sided manifestations are more common in serotonin syndrome. The diagnosis is by the increased 5-hydroxyindole acetic acid in the urine, niacin deficiency, plagra. The treatment is surgical resection, somatostatin analog like octreotide. The rule of one third will metastasize, one third will present with second malignancy, and one third are multiple. Now let's talk about liver, cirrhosis and portal hypertension. Cirrhosis means diffuse bridging fibrosis via stellate cells and regenerative nodules as depicted by the red arrows. Okay. White arrow shows splenomegaly. This is enlarged spleen. Okay, this one. Disrupt the normal architecture of the liver. Increased risk of hepatocellular carcinoma. Etiologies include alcohol, non-alcoholic steatohepatitis, chronic viral hepatitis, autoimmune hepatitis, biliary disease, genetic and metabolic disorders. Portal hypertension causes increased pressure in the portal venous system. Etiologies include cirrhosis, most common cause in Western countries, vascular obstruction, for example, portal vein thrombosis and Budd-Chiari syndrome, and schistosomiasis. So these are the manifestations depicted in this diagram. So in the integumentary system, in the skin, we'll find jaundice, spider angiomas, palmar erythema, purpura, and petechiae. Effects of portal hypertension include esophageal varices that will result in hematemesis, gastric varices will result in melena. Then caput medusae will cause ascites and anorectal varices. The reproductive system will have testicular atrophy, gynecomastia, and amenorrhea. Then in the neurologic system, in the nervous system, there will be hepatic encephalopathy and astrixis, like clapping tremors will be present. The gastrointestinal manifestations include anorexia, nausea, vomiting, dull abdominal pain, and fetor hepaticus, that is, foul smelling breath. Then hematologic manifestations include thrombocytopenia, anemia, coagulation disorder, and splenomegaly. The renal manifestations are hepatorenal syndrome. Metabolic problems include hyperbilirubinemia and hyponatremia, and the cardiovascular problems include cardiomyopathy and peripheral edema. The clinical features of cirrhosis symptoms. The non-specific symptoms are anorexia, fatigue, and muscle cramps, jaundice and pruritus, upper gastrointestinal bleeding, encephalopathy, for example, confusion and sleep disturbances. In women, amenorrhea, irregular menses, and anovulation can also occur. In the men, hypogonadism, for example, decreased libido, erectile dysfunction, loss of axillary and pubic hair will be present. The physical examination on skin, there will be telangiectasias and caput medusae. On the breast, there will be gynecomastia in the males, usually bilateral but can be unilateral as well. In the abdomen, we will find ascites, firm or nodular liver, and splenomegaly. The genitourinary system will show testicular atrophy, and the extremities will show palmar erythema, Murky or terry nails, murky and or terry nails, pupillary contractures, and clubbing. The laboratory abnormalities in the cirrhosis. Indications of liver function. Impaired biosynthetic capacity, that is, there will be elevated prothrombin time and hypoalbuminemia. Impaired transport of the metabolic capacity will be depicted by the elevated bilirubin. Indicators of liver injury. Markers of hepatocyte injury, elevated aspartate and alanine aminotransferase AST usually more than ALT. Markers of cholestasis, elevated alkaline phosphatase and elevated gamma glutamyl transpeptidase. So alkaline phosphatase and JGT level will also be elevated. The other ones include thrombocytopenia due to splenic sequestration of the platelets. Another Uworld point is hyperestenism in the LCA. I don't think it is LCF, I think it is CLF, chronic liver failure. So why is hyperestenism? Hyperestenism means increased level of estrogen. So the causes it is happening due to increased adrenal production of the androstenedione with aromatization to estrone and eventual conversion to estradiol. Estradiol induces sex hormone binding globulin production, preferentially binds the testosterone, which results in increased testosterone binding and a decreased free testosterone or estrogen ratio. The clinical presentation is spiral angioma and gynecomastia and testicular atrophy and decreased body hair. Then comes the spider angiomas. So, subcutaneous vascular lesions consisting of a central arteriole surrounded by many smaller vessels that blanch on compression, found on the trunk, face, and upper limbs. Acquired spider angioma may occur with other hyperestrogenic states, for example, pregnancy, possibly due to estrogen's effect on the arteriolar dilation. The number and size of these skin lesions generally correlate with the severity of the liver disease. The Uworld point is that the degenerative nodule seen in the liver cirrhosis is composed of hepatocytes. The stellate cells can differentiate into myofibroblasts upon the injury to the liver that will result in fibrosis. Subcutaneous bacterial peritonitis is a complication of ascites, so it is basically a complication of complication. Ascites is a complication of cirrhosis, and SBP is a complication of ascites. Also known as primary bacterial peritonitis, common in potentially fatal bacterial infection in the patient with cirrhosis and ascites. It is often asymptomatic but can cause fever, chills, abdominal pain, ileus or worsening encephalopathy, commonly caused by aerobic gram-negative organisms, especially the E. coli. The diagnosis is paracentesis with ascitic fluid, absolute neutrophil count more than 250 cells per millimeter cube. Lab abnormalities in cirrhosis. We have talked about that, right? Okay. Yeah, we'll talk about that. Let's move on. Serum markers of liver pathology. So the AST, aspartate aminotransferase and alanine aminotransferase, they are increased in most liver diseases. ALT is most commonly more than AST. In alcoholic liver disease, the AST will be more than ALT with a 2:1 ratio as well. AST more than ALT in non-alcoholic liver disease suggests progression to advanced fibrosis or cirrhosis. Got it. Alkaline phosphatase increase in cholestasis, for example, biliary obstruction, infiltrative disorder and bone disease. Gamma glutamyl transpeptidase increase in various liver and biliary diseases just as alkaline phosphatase can, but not in bone disease associated with alcohol use. Okay. So to check if the alkaline phosphatase is coming from the bone or from the liver, we check the level of GGT. If GGT is also elevated, so we rule out the bones and we now are very sure that the alkaline phosphatase is coming from the liver. Bilirubin, increase in various liver diseases, for example, biliary obstruction, alcoholic or viral hepatitis, cirrhosis, and hemolysis. Albumin is decreased in the advanced liver disease. It is a marker of liver biosynthetic function. Prothrombin time PT, it is increase in advanced liver disease, decreased production of clotting factor, thereby measuring the liver's biosynthetic function, and the platelets are decreased in advanced liver disease, decreased thrombopoietin liver sequestration, and portal hypertension, that is splenomegaly and splenic sequestration. Signs of severe hepatic failure are increased PT and increased ammonia. Acute versus chronic hepatitis. In acute hepatitis, there will be Kupffer cell hypertrophy. Lipofuscin may be seen. Pan-lobular lymphocytic infiltrate will be there, like the whole lobule will be infiltrated by lymphocytes, because it is acute settings, right? Apoptosis, like Councilman bodies will be seen. This is a Councilman body. It is an apoptotic body, like the hepatocyte being swollen and undergoing apoptosis. That is Councilman body. Macrophage aggregates will be seen, and balloon degeneration will be present. In chronic hepatitis, several months history, more than 6 months. I think it is more than 6 months. So there will be bridging fibrosis, lymphoid aggregates, and periportal necrosis. Then we have the next point, that is over here. So hepatitis B versus hepatitis C virus. In hepatitis B virus, there is ground glass cytoplasm. Cytoplasm filled with spheres and tubules of hepatitis B surface antigen. Finely granular eosinophilic appearance is present. Focal lobular macrovesicular steatosis with lymphoid aggregates within the portal tracts, that is hepatitis C virus. Okay. Acute hepatitis A virus, it is self-limited infection. The clinical presentation in first week is prodromal symptoms. FAHM, what is that? With right upper quadrant pain. Okay. Then we have second week signs of cholestasis like jaundice, pruritus, dark skin, clay colored stool, and then it is also on its own. Okay, so we'll keep this session till here, and we'll continue from the acute viral hepatitis B in the next session. Until then, Allah Hafiz, fi amanillah, and take care.